Sam, you're called to a 40-year-old male who's fallen off a roof that's 6 meters high.
Okay, cool. So we can see we're arriving up to the scene and we can see that it is safe.
Yep, scene is safe. There's just a granny waiting for you, an old lady.
Cool. So you can see the patient's lying here on the ground. He appears to be pale. Looks like there is some breathing effort at the moment. I can see that there's some bloody patches around his head, and there doesn't appear to be any other injury which we can see at the moment. Cool. So we'll go up. I'll get you to get a full set of vital signs when we go.
Alright.
Cool. Hello, sir. Hello. Can you hear me? There's no response to his voice. Hello. Can you hear me? To pain. He's not opening his eyes. He appears to be extending his limbs, and he's got some moaning and groaning. So as long as we've got GCS of 5, I'm going to check his airway. His airway seems to be clear. So he is breathing at the moment. The rest rate appears to be about 12, however it's quite irregular. I'm just going to have a quick listen to the chest. Chest seems to be clear. Just do a quick blood sweep. This is a boggy patch at the back of the head. C-spine appears to be intact. Up here. The ribs appear to be intact. We've got equal movement on both sides of the chest. Abdo is soft. There's no blood anywhere. Pelvis seems intact. Legs are intact. We've got no blood. Okay, I'm just feeling his pulse. So his carotid pulse is present, feels quite strong. His radial pulse is present and
50.
at a rate of about 50.
Blood pressure is 160 over 90.
Yeah, okay. Alright, so because this patient is below GCS 10 and has compromised breathing, we're going to call for R50.
Yep.
So A21 calls control.
Control, go ahead.
We've got a status 1 patient requesting R50 for RSI.
Cool, 10 minutes away.
Alright, cool. So what were those values?
So heart rate is 50, blood pressure 160 over 90, breath rate 12 and irregular,
Cool.
BVR 7.6, temperature 37.
Alright, sounds good. Managing the airway with the OPA. He seems to be tolerating it. I'm going to put a non-rebreather on this patient because we want to put him on high flow oxygen. We put our oxygen on 15 litres per minute, so we want to prevent hypoxia because we're potentially thinking that this patient has a TBI at the moment. I'm just going to keep the torch out. Appears to have unequal movement to the left side of his eye. Alright, so we've got that on. He appears to be quite combative at the moment, so I'm just going to, before we move him, I think I'm going to get IV access, and if I could get you to pass me the IV roll, and you could organise some extrication.
Yep.
So I don't want to put on a C collar at the moment, just because he's got a, just because he's got that boggy patch at the back of his head. I don't want to cause any further damage. So I'm just going to try to keep him as still as possible with still thinking about C-spine. We're in the ambulance now. We've got the patient, we're on the stretcher. So we're just going to reassess our GCS. So, Frank, can you hear me? No response to voice. To pain, he's still closing his eyes, extending to pain, and appears to be moaning and groaning. So still GCS of 5. Frank's still below GCS 10 and still has irregular, compromised breathing. So we're going to start moving towards our backup, and I'll get you to start attaching all our monitoring equipment. So we're going to start moving towards our R50 and start preparing for RSI. Alright, so we get the monitoring equipment on. We've got our non-rebreather on at 15 litres per minute. And I'm going to get the patient in the sitting position. At the moment we've just got 2 towels around the side of the head just to stabilise the spine for now. So get the patient in the sitting position. We need some nasal prongs ready underneath the non-rebreather.
me to move off?
Yep, yeah, I'll get you to move off. Get our endotracheal tube holder and underneath the patient there. Get our bag valve mask ready with PEEP attached, 5 centimeters of water. Attached there. Make sure I've got my end-tidal CO2 in the monitor. So I'm going to start getting a full set of vitals now as well. So I've got one IV access on this side of the arm, so I'm going to attach that up to fluid and run that, and I'm going to get another side of access on the other arm. Alright, so we've got everything there. We'll grab our suction as well. So we've got our suction, we'll make sure that it's working. So suction's working, I'm going to get that placed underneath the head there. Now I'll make sure I'll declutter the area, make sure there's a good clear room around the head for intubating. Get that out of the way. So we've got the monitor over here in a clear position that we can see. That's good. Now I'm going to go through my RSI preparation checklist. Alright, so we've got nasal prongs attached. We're pre-oxygenating with a reservoir mask. We've got our monitoring equipment, ECG, blood pressure, SpO2 all attached. We've got our end-tidal CO2 attached. We've got the monitor in a position where it can be seen. We've got space at the patient's head for the intubation roll. We've got 2 sites of IV access with a running line of saline. We've got a endotracheal tube holder strapped underneath the head. We've got the head in the sniffing position. We've got suction near the head and is working. We've got our bag valve mask with PEEP attached. We've got a set of vital signs, and so we are ready for intubation. Alright, so once the ICP has arrived and we want to assist them in their RSI procedure and intubating the patient, so to do that we can help them initially by making sure that the patient's adequately sedated, so we can use fentanyl and midazolam for that. Also, so once the ICP's here, we can help them pass any of the equipment they might need, like a bougie or endotracheal tube, when they're ready. So we can also help them while they're intubating as well with using the invert manoeuvre. So you place your fingers on the trachea here and you place backwards, upwards, rightwards pressure to help them visualise the chords when they're intubating. So we can also help them with intubating when they've got the bougie, and we can help pass over the endotracheal tube over the bougie. So if they're unable to visualise the chords and intubate within 15 seconds, they'll reventilate the patient to gain adequate oxygenation again. If they fail again, then it'll be they'll need a post-intubation management. This will be reverting back to basic airway care, where you go for an OPA or an LMA. And if that isn't quite adequate, then the ICP may consider CRIC, where we'll also be able to assist.
You're dispatched to a 70-year-old male who's complaining of chest pain and has collapsed. It's sudden onset of chest pain, and he's unable to stand due to near syncope and dizziness.
Okay, so he's at home?
Yep.
Then we're in the middle of the night?
Yep.
Okay, cool. And so we're walking up to the house. It appears to be safe.
Yeah, you're greeted by his wife. She's a bit worried.
What can his wife?
She's just really worried and wants you to come in and have a look at her husband.
Cool. Right then, we'll go in. I'll get a full set of vitals,
yep.
and we'll have a chat to him. So we'll walk up to the patient and see he is a alert to my presence? Is
Yeah.
he talking to me?
Yep, he's talking. He's a bit confused, but.
Hello, sir. My name's Sam. What's your name?
Oh, Frank.
Okay, so I can see his airway is open. I see he's breathing quite normally. He looks very pale, sweaty, and I am unable to feel a radial pulse. And so also looking at his capillary refill peripherally, it seems to be about 6 seconds long. So what's going on here, Frank?
I just woke up all of a sudden to chest pain. I had an MI last year, 5 years ago, but it feels real different.
Okay then. So can you tell me what day it is today, Frank?
Oh,
I'm just going to put these leads on your chest.
I don't know. New Zealand?
So he appears a little bit confused at the moment. He also appears to have a unrecordable radial pulse, and he's very pale, clammy, and a increased capillary refill time at the moment. Can you tell me about that chest pain?
I feel palpitations going into my neck, and my heart feels like it's going to jump out of my chest.
Okay, so you're on any medications at the moment?
Cilazepro and aspirin.
Okay, and so you've had an MI before, is that right?
Oh, I believe so.
Okay. Now we're just going to have a quick look at your heart, okay?
Blood pressure is 70/40.
Okay, cool.
Connect
Rest rate
electrodes.
18. BGR 7.6 and
Yep.
temperature 37.
Yeah, okay, cool. Alright, A21 pulse control.
Control, go ahead.
We've got a status 1 patient requesting R50.
Sure. 15 minutes away.
Roger, alrighty. So, I'm just going to have a little look at your heart now. So we're looking at the monitor, it appears to be in a VT on the monitor at the moment at a rate of about 170. So we're just going to get a 12 lead as well. I'll get you to pop that on actually. Okay, so looking at our rhythm, it appears to be a wide and bizarre QRS. It's wider than, it's 0.2 seconds long. Now it's most probably a VT because it's faster than 150. This patient here is over 35 years of age and also has ischemic heart disease. Okay, so we've got that 12 lead on. Also, could I get you to put an acute mask on? Just because this patient is appears to be in shock at the moment, so we'll get that acute mask on 8 litres per minute. Now I'm just going to get this 12 lead printed out as well, just to confirm that we're in VT. And then what we're going to do, I think we're going to consider cardioverting this patient. So are you still with me there, Frank?
Oh, yeah.
Yeah, now we're just going to pop some big dots on your chest, okay? Can you get the resus kit out as well?
Yeah, sure.
Alright, Frank, now we're just going to lie you down, okay?
Okay.
Alright, we're laying down. So, how long has this pain been there for?
Oh, it just came on all of a sudden. 20 minutes.
Okay, then, cool. Alright, so we're going to gain some IV access as well, and also I want to give him some sedation as well, so we're thinking of cardioverting, but because he's still able to obey commands and is in a moderate level of cardiovascular compromise due to his VT, we want to sedate him. So we're going to do that with some fentanyl, so we'll probably start off with a dose around 40 micrograms, and we'll also consider calling up clinical desk as well to ask for permission to use midazolam to provide some extra pain relief. Okay, so once we've given that and he's visibly sedated, you still with me there, Frank?
Yeah.
Yeah, so he appears a little bit more sedated. We're going to put the monitor in manual mode. put it in manual mode, we're going to put it in sync. We're going to ensure that we've got a detection symbol over every QRS. We're going to make sure we're in the highest lead with the highest amplitude. Yeah, cool, so it looks like we are. I'm going to minimize artifact, and we're going to get out my checklist. While I'm doing that, could you just have a quick listen to the lungs as well? Alright, so our cardioversion checklist, we've got the pads on, we've got the defibrillator in manual mode, we've got the limb lead with the highest R wave, we've minimised artifact, we've got it in synchronised mode, we've got a detection symbol above every QRS complex, the patient's been adequately sedated. So we're going to select the joules, we've done that when we put it in manual mode, we've got maximum joules. So we're going to charge up the monitor now. We're charging up, so everyone stand clear. And so we're going to shock, so everyone stand clear, shocking the patient, holding the button down and shocking. So doing that, we're now going to reassess our ABCs. So Frank, can you hear me? Can you hear me, Frank? General response to pain?
Still responding.
Okay. Oh, his airway appears to be clear still. He's still talking to me. I can see his breathing is quite normal. Alicia, that's cool. I'll get you to get some more vitals for me. I still am unable to feel a radial pulse. His peripheral recall time still seems to be about 5-6 seconds. Get another rhythm strip printed out. So it looks like he still seems to be in a VT with a moderate level of cardiovascular compromise. He's still at about a GCS of 13 at the moment. What are those vitals?
Blood pressure still 70, so still up.
Okay. So we're going to ensure we've got adequate sedation, and we'll consider cardioverting one more time to see if that has an effect. So doing that, we'd go through our same checklist, and we would repeat the process which we have just done.